I'm joined by such an incredible powerhouse of women today. And everyone's going to be able to share a little bit about kind of where they come from and the work that we're doing. But this is who we have right here: Anne Marie Murphy, Jeanette Averett, Helen Haskell. I am Suze Schrant with the Society to Improve Diagnosis in Medicine, Kathy McDonald, and Christy Mitchell. And so, as I said, you'll learn a little bit more about us as we move forward, and about the work we're going to do, or the work we do, and the conversations we're going to have about that work. But just wanted to give you a sense for who you're hearing from today. So let's go to the next slide. We'll very quickly show you the agenda. And we've even got, minutes down to the 2 and 3 minute mark, just because we have a lot to get through. But we're going to share a little bit about each of the organizations who are represented here, and then dive right into this disparities project that was a partnership between Johns Hopkins and SIDM. And we've got equal hope and health equity outcomes as these leaders in the diagnostic qualities in the health equity space to join us to talk about the potential findings and what we can use the project findings for, how it might resonate. And so really looking forward to having a rich discussion about what we learned and what we want to continue working on in this arena of health equity. And of course, plenty of time for audience Q&A. And again, please use those Q&A and chat functions. So let me just kick us off by talking about the Society to Improve Diagnosis, or SIDM, real briefly. If you're not familiar with SIDM, we're the only group that is focused entirely on diagnostic quality. There's a lot of groups that focus on patient safety, which is hugely important. And then SIDM really focuses on a piece of patient safety, which is diagnostic safety and combating diagnostic error. And so the idea is that SIDM is meant to be the premier resource for innovative solutions to reduce these medical errors that arrive from missed and delayed diagnosis. You can see there we have our listed values, and right at the top is patient centricity. And really our vision, our purpose is creating a world where no patients are harmed by diagnostic error. We have a coalition of many patients and patient groups, clinicians, researchers, industry partners, academic partners, government partners. So it's that idea that it really does take a village. And so SIDM is positioned well by having a lot of really important partners, many of whom I am assuming are on the line with us today. And so that's a little bit about SIDM. I'm going to turn the reins over now to one of our partnering organizations who is on this webinar. So Anne Marie, I'm going to give it to you.
Sure. So I run an organization in Chicago called Equal Hope, which was formerly the Metropolitan Chicago Breast Cancer Task Force. And our mission is to save lives by eliminating health inequities. We do that by challenging the status quo, striving to understand the context of people's lives and the barriers that they experience both in the healthcare system and beyond the healthcare system that affect their ability to have their best health and to survive. We work through research, quality assessment, and improvements and advocacy. The advocacy is to make system change, to sort of glue in changes. We also are engaged in education and patient navigation, and we seek to promote health holistically and achieve health equity. In the next slide, I think I'll show we were born out of research that showed large and growing disparities in breast cancer between Black and white women in Chicago. Oops. When we first started in Chicago in 1980, which was before we started, there was no disparity. But by 2007, when we started, the disparity had grown to a 62% disparity. And our slides somehow are just having a life of their own.
They are automated.
I apologize. I think they're self-automating. Sorry about that, Anne Marie.
I'm like, I know what they say, but may prove a little discombobulating for everybody else.
Can you see it, our central hypothesis?
I can see that.
Do you
Okay.
want to go back up to the very first one with the
Yes, the
yeah,
graph,
let's
that one.
leave there. Yeah.
That would be lovely.
Okay.
So what you can see from this slide is that in 1980, Chicago basically had no disparity between Black and white women. But by 2005 to 2007, that gap had grown to a 62% gap. At the same time, New York had almost no disparity, and San Francisco had very low disparities, but for breast cancer. But there are some other cities like Memphis, Houston, LA had high disparities. Now, it's hard to argue that Black women in New York are genetically different from Black women in Chicago, or genetically different from Black women in Memphis or LA. So it seems far more likely that structural racism is in play here. And in fact, if we go to the next slide, when we established our project and we looked at a wide variety of not just mammography, but mammography and treatment, we found quite disparate access to resources, whether it be digital mammography. Today, that divide would be between tomosynthesis, 3D and 2D, whether you have access to specialist mammographers, specialist surgeons, breast oncologists, etc. We did a lot of work over a decade, and in the next slide, you will see we published a paper in 2017 that shows that Chicago is now #1 in the nation after our about 14 years worth of intervention. We now have reduced Black women's death rates from breast cancer by 14%. And the death gap for breast cancer is now actually at a 32% gap. So that's all good. The next slide will show you what our hypothesis is. We believe that at least some, or actually a significant amount of the breast cancer disparity is driven by unequal access to high quality care. Obviously, we believe there are other components that drive disparities, including breast cancer disparities. But this aspect in regards to quality of care, we think does drive a good portion of it. The last slide I'll show you is the model that we have developed. We believe that to address health disparities, you cannot do that at one institution alone. You have to have the whole community in. You have to understand the full landscape and how everything connects together. You need to build a big tent with everybody in and develop consensus on what quality is. And then when you gather that data, after you've gathered the data, then you should plan your interventions. At the same time, the patients should be at the center of everything that you do. So that's our model and how we've done it. But as we get into, errors in diagnostics, plenty of the work that we did involve looking at diagnosis and failures to diagnose breast cancer. I will pass it on to the next.
Great. Thank you so much, Anne Marie. And, it's both sort of terrifying to see the data from where you started, heartening to see how much progress you've made. And I think where a lot of the learning is in your model and really being driven by the lived experience of patients and communities. So thank you so much for sharing that. I think we got our wild slide timing issue fixed. We'll see. So Christy, I'm going to hand it over to you. And if the slides act up, we'll just go back to the other view, but take it away, Christy.
Yeah, no worries. So thank you, Suze. It's my pleasure to share a bit about my new organization that I recently launched called Health Equity Outcomes. It is a San Francisco based nonprofit that actually got its start in 2021. So we are very new. So if you go to the next slide, I'd like to really just talk a bit about our mission. So overall, it is to empower underserved communities to engage in research in a more effective way. And we're thinking about it in terms of advancing health equity from the inside out. More specifically, through our efforts, we seek to provide education, tools, and resources for community health centers, like federally qualified health centers or substance abuse centers, to become viable strategic partners in designing, collecting, analyzing real-world data that's meaningful to the community, while at the same time serve as potentially a revenue stream for community health centers. A lot of people ask me, well, why did you start with community health centers? Like, what's the allure in working with an organization that's typically underfunded, that are pretty much seeing the underserved community, Medicaid and underinsured or uninsured? And my retort is, of course, they serve 30 million patients across the country. If you really want to tap into how we can advance health equity, we need to go to where the people are. And so we are building an entire model around uplifting the community health center as that centerpiece. So on the next slide, you'll see really how we envision how the community health center intersperses with the community and serves as that fulcrum to touch upon the social determinants of health. Sorry, I just had a brain fog there. And we really believe that the community health center is that centerpiece for building trust. And when we start talking about being patient-centric, it often has to be taken into context from where they come from whence whence their experience emerges. And so again, when we think about the role of that community health center as being central to that, and you overlay the role of the patient, we think that, again, this is a really good place to really lean in. So when we also look at the external environment, so you've got life science companies, so pharmaceutical companies, device companies, all trying to figure out how to generate real world evidence differently, how to close race and ethnic disparities. And oftentimes they don't think about working with these particular centers for doing so. At the same time, Biden's administration is committed to not only raising awareness about the role that structural racism has and continues to have on communities of color, but to actively commit to doing something different. As a result, the federal government is going to be incentivizing health plans and accountable care organizations to engage with communities to tackle health disparities. And so, again, it all circles back around to what is happening with the community, who's engaging with the community, and how do we effectively bring the patient and the population to the table. From our perspective, the time is now to get engaged and involved, and it's probably time to do it now. And so on this last slide, because again, this is all about trying to explain this model. We've got a few projects that are percolating right now. And so, if we were to talk to you in about a year, we'll have some data. But the idea is, how do we do this in such a way that is, recognizes the strength of the community, but also notes that communities need support in building infrastructure. Communities need support in actually engaging with other members of the community. And so part of our roadmap is to identify those centers who are interested in doing research, but then committing to doing three things: increasing research literacy, enhancing sort of the types of data that they're collecting and how they're using those data. And the third one is engaging with sort of strange and unusual partners actually in those communities. So whether it's a Dollar General or a Kroger Health, perhaps organizations above and beyond the faith-based organizations that they may already be working with. And then we really move forward on establishing this research collaborative and supporting ongoing engagement and data collection. And really the full vision is to infuse the community with future jobs, to support ongoing engagement and data collection, and ultimately a certification will be developed to further lower the bar for researchers to collaborate with these organizations. And if I didn't say it once, I'll say it again. If we don't keep the patient at the center and truly sort of support research from that lens, then we're really truly are going to be at a disadvantage at advancing health equity. Thank you. Looking forward to talking with you all as we move forward today.
Great. Thank you so much, Christine. There was one question that came in that I just wanted to make sure we responded to. Adrian Jacoby asked what the definition of community health center was in this construct. I believe it's an FQHC, but I wanted to send that to you.
Yeah, that's an excellent question. So community health center includes FQHCs. We're talking about substance abuse clinics as well. But they don't have to be FQHCs. They could be also nonprofit community health centers as well. So they're not 100% receiving government funding. I hope that helps.
That's really helpful. Thank you. And then another question, just quickly, is what are life science companies? So how are you defining that? Okay.
Absolutely. So a life science company is a pharmaceutical, a device, or biotech company. So they make prescription drugs or new devices and the like.
Great. Thank you so much, Christy. And exciting to see your work. I think any of us who have looked at, disparity in the diagnostic quality space, FQHCs and other free or reduced care clinics are such an important starting point for the diagnostic process. And so that's such an important piece of the entire sort of landscape of diagnostic quality. So thank you.
Yep.
And at this point, I'm going to turn it over to my colleagues, Helen and Kathy and Jeanette, to talk about sort of the reason that brought us all together, which is the results and findings from the Johns Hopkins and SIDM partnership. This was our Disparities in Diagnosis project. And so, Marie, if you can go to the next slide. I am going to hand it over to you, Helen, now, I believe. Or is it Kathy first?
I think I'm going to give us the first
Okay,
overview and move quickly to Helen.
Great. Okay.
So yeah, we're presenting about a project that we've worked on for the past few years and that culminated in the report that's shown here and is available on the SIDM website on diagnostic error disparities, both exploring what causes disparities and trying to address those disparities to reduce and ultimately eliminate them. The project was funded by the Coverys Community Healthcare Foundation, which invested quite a bit of money into multiple disparities-oriented projects and diagnostic error projects. This one included a patient advisory board and a research advisory board, so bringing together participants that were patients, the care partners of patients, patient advocates, researchers, clinicians, and many others like health IT professionals and educators. The project focused on disparities that were related to visible factors, something that when a patient comes into a clinical encounter might be seen and observed by the clinician and might influence the clinician in some way, or the setting of care might be more easily accessible or less easily accessible in some way connected to those visible factors. And we used various human-centered design approaches to work collaboratively with all of the participants in a series of workshops. And I just wanted to, prior to passing on to Helen to give more of the details about the project and who was involved from the patient perspective, I wanted to just define human-centered design because it undergirded our work and it ties into what we've just been hearing about in terms of really co-designing and co-creating understandings and solutions. It's considered a collaborative and creative process that starts and ends and everything in between with the people most impacted by design solutions, so the changes that would be needed, and aims to do this through a co-design effort to achieve the products that are needed, the services that are needed, the systems that are needed to address their core needs, those who are most impacted by the solutions that are generated. And we did this with a lens of justice and equity, meaning that we wanted to design more equitable and desirable solutions. So that was the overarching frame of what we did in terms of workshops. In terms of the patient advisory board, which was absolutely critical, I want to pass on to Helen to fill you in about that.
Okay, well, thank you, Kathy, and thank you, Suze. I just want, so in this project, we focused on visible factors. So the factors that clinicians and diagnosticians see when a person first presents, things that are really obvious: your race, or ethnicity, your age, and your gender, sex. Some others came into play, but these were the ones we were focusing on. We had a set of patients who also had experienced what we call the big three at SIDM. So the top three buckets in which we put diagnostic problems. They're not the only buckets, but they're the biggest ones. And these are cardiovascular problems and problems with infection or sepsis and problems with cancer. These are really sort of vulnerable areas for diagnostic error. So we had, as you can see, we had 6 patient advisory board members, plus Kathy there in the middle, who was our leader. And we sort of had them representing each of those 3 categories. So for example, we had two of each. So 2 representing each of the 3 main diagnostic areas: cardiovascular, infection, and cancer. For example, we had 2 people representing infection, so a white woman and a young man, and 2 people representing cancer, an African-American woman and a young man. And I have to say that the 2 young men were represented by their mothers because both of them were deceased. And one of those young men was my own son, Lewis, who died of peritonitis and sepsis and blood loss after an undiagnosed perforated ulcer in the hospital following elective surgery. Because one of the major reasons was that nobody could really wrap their mind around the idea that this young, healthy teenager could have something seriously wrong. And that was a fatal assumption. I want to now pass it over to Jeanette to give her a little bit more about her story, what happened to her with diagnostic error, and how she thinks that that this sort of bias might have entered into it. So, Jeanette, are you able to unmute? Well, she may be having some technical problems. I'll just start by saying Jeanette had a cancer diagnosis. There she is. Can you unmute Jeanette? There you go.
Okay.
Great.
Can you hear me?
Yes, you sound great.
Okay. Well, my name is Jeanette Abrett, and I come to you with experience of, in my opinion, of sluggish diagnosis. My professional role is as a registered nurse, and I happened to visit my doctor. I had some complaints of just being tired, I knew that I probably had an anemia problem, but I felt like I had to be almost standing on a table for them to even look at all of my labs, my CBCs. Like my doctors were like really taking it lightly. Well, maybe you're not getting enough rest, and it was this or that, but I knew that was something more than that. But long story short, as it turns out, when I was diagnosed with 3rd stage colon cancer, colorectal cancer. And it was shocking to myself, but it was doubly surprising to my doctor, because as I kept telling them, no, this is not that, they were really hesitant on going further. So I feel like I shouldn't have had to keep advising them to look further. They should have just did it automatically. But that caused me to have a colostomy award for 13 months. And it was a very devastating time for myself and family. And I don't know whether they took a look at me being a Black woman and just minimize or reduce efforts to look further. Yes, they finally did listen to me, but I don't think that I should have gone through what I went through. And I'm fine now, but I still see my oncologist twice a year. This was in 2013. And I just think that a lot of it could have been identified earlier and the complications would have been reduced on my end, on my family's end, on my health. And I will have to see my doctor from now until I leave this earth, because as I requested a genetic test, and it is a genetic condition that I suffer with, but they were just hesitant to go further, and that bothers me still to this day.
Thank you, Jeanette. And I think we'll talk a little bit further. We've got a long discussion section. I want to talk a little bit further about some of the components of your case, because I think there's a lot to be learned there. But at the moment, I want to just go quickly through some of the rest of this project. So we had in the project, as Kathy mentioned, we had 4 workshops. And really beginning, even in the very first one, it just sort of naturally fell into these 4 categories, these 4 ideas of where the problems lay. So patient-clinician interactions, how workflow delays, changes in the environment. What is the optimal environment that people need to be in? I see we're missing an N in environment. I just had, but and then the health information and accessibility, which is critical education and access to care and to information. Next slide, please. Yeah. So some of the breakdowns of this, some of the more detailed things are the ideas of fostering trust, creations of checklists for both patients and providers, which are really helpful, equalization of access to the patient portal. I won't go into all of these, but they're all really helpful. And communication strategies, of course, is a big one, potential types of solutions. And then next slide, please, Marie. Breaking it down even further, these are examples of some of the very specific solutions that we came up with over the course of these 4 human-centered design workshops. So, for example, visit preparation guides, which are a great resource. They exist, but they're not always focused on diagnosis. So we can, have these particular things that could be added that would facilitate diagnosis, would smooth the path, facilitate conversation about diagnosis. Same, here's another follow-up telephone call process, making it more targeted and individualized and more like a navigation program that Anne-Marie was talking about. So next slide, please, Marie. And now I'm going to turn it back over to Kathy to talk a little bit about the process by which we came up with some of these things.
Thank you, Helen and Jeanette. Yes. So this project had the idea of coming up with solutions, ideating around solutions, being able to co-develop solutions, but we needed a process to do that. And I mentioned human-centered design as the process, the tools from that we used. And one of the ways that we did that in a really concrete manner was in these workshops, putting forth a design challenge. And the way a design challenge works is it says, okay, you have insights, you have your lived experience. We had presented information from the literature and understanding what was known and researched already about disparities in diagnosis. We had some data from malpractice claims, and we had interviewed members of our patient advisory board and had them participating alongside of researchers and clinicians. And we said, in the context of a workshop with those people and others, if those insights could be used to create a design challenge statement. And the technique we used from human-centered design was what's called a how might we statement. And how might we statements, which are this design challenge, help brainstorm solutions during an ideation phase while you're trying to come up with ideas. And they're crafted as open-ended statements. And excuse me if it's loud, I'm in the middle of a thunderstorm. Open-ended statements of possibility that would be desirable in an area of potential growth. And just to make it really tangible, in these how might we statements where you say, how might we, some sort of action verb, then who would be affected by a solution and what behaviors might change. What you want to do in a group is not have the statement be too narrow that it doesn't give room for coming up with a wider range of solutions. And you don't want it too broad that it keeps the group from being able to get specific enough to have something that could be done. And in our process, we could have had a statement and did as the groups were working. Things like a too narrow statement would be something like, how might we design a visit preparation guide? What Helen was just showing as one of the prototypes for elderly women who have experienced heart problems. That would be pretty narrow because it's already saying there's a solution. There's the visit preparation guide. And at this stage of ideation of a design challenge, it's a much earlier stage than the prototype stage where you have more specific solutions and now you're trying to get even more details in a co-design approach. And then a too broad how might we statement would go something like this. How might we help all patients prepare for their visits? So you're going for this Goldilocks thing of just right to get that well-framed design challenge collaboratively. And the design challenge, how might we statement could end up being, how might we help patients who are vulnerable to experiencing diagnostic errors caused by visible factors like their age, sex or gender, race and ethnicity, feel supported in preparing for their diagnostic encounters. And then the preparation, the visit preparation guide would be one solution among many that would be how to support patients and their care partners as they were going through their diagnostic encounters in ways that accounted for possible vulnerabilities related to their visible factors. So that's just a piece of what we use, this idea of the design challenge to make it more tangible, what we did. And the other thing that came out of the process, next slide, please, Marie, was principles to be working with diverse stakeholders in this solutions generation approach informed by human-centered design. And here we have what the groups that we got to engage with through this process in this project, 6 principles that are targeted at working in the diagnostic disparity area and hit on what the group felt were important to articulate and continue to come back to in the work. So, you know, in brief, there's ensuring that we were focusing on equity. The second is recognizing that bias isn't something that is unaddressable, it's addressable. And then the third here is incorporating patient-centeredness philosophy and ideas that each patient's unique and are playing a critical role in their diagnosis. The fourth principle was about supporting patient empowerment, understanding that there's a lot of asymmetries in knowledge and power, and it would be important to focus on the importance of each individual's own lived experience in any aspect of our work and coming up with potential ways to make improvements that would address disparities and inequities. The fifth was, I think, a really important one, which was to highlight how engendering the trust of those who we are working with as patients, whether it's in a clinical context or whether it's in this design challenge and activities, and acknowledge how the process could be different within different subpopulations. So that one needs to keep coming to the forefront. And the last reflected the work that we did together in this project and the shared understanding that patient engagement throughout the process of solving diagnostic disparities is important, and that patients and their advocates are important in leading change and working to get others to join in the places that matter most. So we are bringing those to the discussion today too, and we'll look forward to talking about how they relate to other the work of others in this area.
Great. Thank you so much, Kathy and Helen and Jeanette, for walking through the project, but also Jeanette and Helen for sharing your personal stories and really kind of grounding us in why this work is so important. Now we're going to dive into the discussion. And if we go to the next slide, Marie, there was so much in this report, and I saw a question come up through the Q&A asking if these slides are shareable. I'll want to confirm with all my fellow speakers that we can share the deck, but I should have mentioned some of the pieces that you're seeing about the project are actually in the final narrative from the project, which is also publicly available. So we'll make sure everyone has access to anything they would like. But taking this multi-year project and trying to distill it in a brief webinar, we thought we might just focus on two different pieces that you've already been exposed to a little bit. And this is where we'll be able to really get into some discussion with Christy and Anne Marie and with Helen and Jeanette and Kathy about, what do we do with these results and what resonates? So let's just start with these focus areas for solutions. And as you heard Helen speak about, this sort of for us naturally fell into four buckets: patient-clinician interactions, workflows, changes in environment, and then health information and accessibility. So maybe let's start with Anne Marie, because you're top in my list of videos. Just with that first question, do these focus areas resonate with the work that you do and the communities that you serve? And it's okay to say no, because we know this is an ongoing, conversation and work stream.
I think the answer to that is yes and no. Yes, we certainly find all of those four are areas that lead to disparate outcomes. We've done plenty of care process analysis that found disparate resources and disparate care pathways depending on where you are and how much resources places have. And safety nets often have very little money and don't have, therefore, the ability to have navigators unless they're grant funded, and a lot of other support staff. Their IT systems may, be more challenging. Then there's a new study out from the University of Chicago that they looked through all their medical notes for their entire system. And what they found was that there was a much higher number of negative comments in the notes related to patients of color, using the words like aggressive and non-compliant, and the list went on. And you can just imagine, in the notes, the next healthcare professional comes and what did they see? Oh, that patient's already been tagged as aggressive or non-compliant or whatever it is. So yes, on the one hand, yes, we see all of these areas as problematic. But the no is that we also see one that's not on this list, which is referral pathways. You can do all this fixing at this one spot, but many people don't ever get there. So for instance, if you map out all the Academic Commission on Cancer accredited cancer programs in Chicago, and you layer that on top where all the predominantly African-American areas are, the accredited facilities are all in the affluent white areas. And the areas that have the highest death rates for cancer are the areas that have no either NCI cancer centers, or they don't have breast imaging centers of excellence, and they don't have Academic Commission on Cancer accredited programs. And we published a paper that came out just at the end of last year that said where you enter the system often correlates with your downstream quality. So not just the quality of what you got when you went to that facility, but the care you might have gotten later. And so your referral pathway to quality is bumpy and often non-existent. So as I said, in summary, yes and no.
That's so important that, and again, it makes me think of so much of what we focus on in diagnostic quality is there's no such thing as too far upstream to make sure someone gets to the right diagnosis. I'm curious if Christy, Helen, Jeanette, Kathy, any reactions to what Anne Marie said? I should have said you're all welcome to jump in. I don't have to call on you if you have something you want to say.
I'd like to start, if I could. First of all, I want to commend you guys on a fantastic body of work. I mean, both in terms of the methods that you chose to use, which, by the way, I mean, I embrace human-centered design because I think it's foundational to a new way of deriving evidence and information. So thank you for embracing that approach. But I think it's the model that you offer at the end that I'm most interested in adopting, sort of moving forward. We can talk about that in a bit. But as it relates to this particular topic, the focus areas for solutions, they're very consistent. I mean, nothing on this page jumps out at me as being wrong. So to Anne Marie's point, yes and no. So I think what's on here makes 100% sense, makes all kinds of sense. What may be missing, at least in my interpretation of what's in these 4 boxes, is around the patient's own health-seeking behavior. I don't know where the patient part is sort of incorporated. So for an example, you can raise awareness about the need for certain diagnostic tests, but if the patient themselves aren't activated to do anything, so outside of sort of when they interface with the medical system, there's this piece beforehand, and I wasn't certain if you thought that was within your purview or not in this particular model. So I think that's more of a question than a comment. So I don't know, but I'll pose and I'll stop there.
So I might just respond a little bit. I appreciate this chance to kind of open more territory, which was the idea of the process. The process was keep generating an open territory. And what these 4 areas were what was collected from, what the workshops created. And they were creating the ideas about solutions from the lived experience of those who were in the rooms. And so they tended to gravitate towards that interaction with the clinicians or gravitate towards something that was happening in the workflow. Workflow could include referrals, from one setting to another setting. Access where you come into an environment, which environment you're coming into can relate to some of the changes in environment. But many of the discussions and the solutions that were generated as the beginnings of possible solutions from this whole process were so tied to actually someone having had consequential diagnostic delay, something, as Helen said, fatal, mistakes with assumptions that had major consequences, that the focus on, like, when did that happen, the sources that were happening very close to the huge gaps in care were more, were surfacing more than some of the structural problems that are important. They were acknowledged, but not as much of the focus for this particular group at this particular time. So I appreciate that we're raising those here, and just think of us as one of our biggest findings was this process of trying to apply the human-centered design in the space of diagnosis and in the space of disparities at an intersection was fertile for creating the chance to surface anything that anyone in the process wanted to surface, and not just tie into one solution and end there, or one problem and end there.
Probably, if you look across the full continuum, you find problems at every single stage. And this particular project, if you're focusing on patients that have experienced diagnostic misadventure, they have to have come in contact with the healthcare system. Therefore, they're in. And so you're looking at a variety of problems having arrived. And of course, there's a whole variety of people that never arrived. And those are different. Maybe those are other projects, maybe they're next projects. It's just that as you go from a person living in the community all the way through, I think you find challenges at pretty much every step of the way. There are structural barriers that impede access to the best care for many.
Yeah.
I agree with that, and I appreciate, thank you for that clarification. And I suspect the other sort of barrier that jumped out at me that's in need of a solution is around graduate medical education and sort of the opportunity to begin to infuse medical training, and I would say clinician training. I don't want to just put it at the feet of the physician, but across the board around health equity, around disparities, and around just implicit bias, unconscious bias, all of those things that go into, as you said, diagnostic misadventures, medical misadventures, as it were. So curious as to, did you guys stumble upon that? And if so, which bucket does it fall under?
We definitely had that. Yeah, I think it sort of falls under patient-clinician interactions. It's training. But we have some recurring themes from these various stories that we have, and one of them is trainee just sort of obliviousness to the problems of different groups. This is something that needs to be taught, and there's sort of an assumption that that these kids, well, I shouldn't say kids, these young people already know it, and they don't necessarily. They're having to take in so much that they're just not questioning. That's my take on it.
Yeah.
Jeanette, yeah, jump in.
Okay, I have a comment. I was just thinking about all the possibilities of why the disparities levels are as they are. And I just sat through all that and just thought, we as people, we as human beings, we really need to re-examine what our biases are. Because a lot of times we come across like, I really want to help you, even though there may be a good program or on the other side. But if you come across like, I don't even care to be bothered, people can read that. And I know a lot of people have had experiences coming from other clinicians that they also carry. So it's just a matter of, human to human. It doesn't matter what race. Just be nice and be professional and be like you would want to be treated. And what make you think that it's okay to just be dismissive or nasty, or I don't have time? Is that really what you went to school for? Because if we can come up with all the solutions in the world, but if we as people are just downright nasty in our disposition, or we come across like, I don't really care about you, I'm only here because this is my job, I guess I can say that, then we are going to overlook a whole lot, because people have layers and layers of social issues that they're already dealing with. Health is important, but it may be not to them at that time. I think we should just put on our best show, just even if we say, I'm going to be the best that I can be. But if we're not even there, this is not going to change.
Yeah, I agree with Jeanette, like 120%. One of the programs that we've been doing recently is a primary care program where we're paying for the first visit, because we've seen in Chicago a great increase in the number of people that don't have a regular primary care home. But even when we're giving it away for free, lots of people don't necessarily want to go to any medical location. They have been disrespected, they've had poor experiences, they've felt unheard, brushed aside. So, you can't pay them literally to go. You'd always be given a lotto ticket. Would you go to the doctor? Here's a lotto ticket. Because it doesn't seem like a good use of time unfortunately, to some people. And the solutions there are really hard. It's very hard to design an effective intervention to build trust where trust has been lost.
Mhm.
This is so great, and I want to keep going down this thread, but I noticed a couple of questions in the Q&A, and I want to make sure we look at those. One is from Ted Fox. It says, concern: all studies, initiatives, and solutions with monitoring are dependent on leadership leading, not just agreeing. It has to be in the center of their plate. What success and advice do you have regarding this challenge? And I think Jeanette already kind of outlined a great operating concept that we need to bring our best selves. So I think that's one important piece. But what any other answers to that question? Okay, maybe we can take some time and think about that. And the other question is, what is the mechanism by which such notes are shared by healthcare providers? Is it possible to prioritize navigators for those called non-compliant? So I'm not sure.
This seems like it related to the study that you were talking about, right, Anne Marie, which one of my colleagues at Hopkins is involved in.
This is Monica Peaks is part of that group. Monica Peak is a wonderful African-American physician, breast cancer survivor. I'm sure she's well, I talked to her actually about this particular study recently. So these notes are, in the electronic health records. Providers write in their, the results go in, and then they write in notes. And so the next provider that comes along, when they pull up that file, they see these notes. But now, one of the challenges with notes is that notes, unlike when you have something that is actually a data entry point that you put in, if you had quote non-compliant, yes, you could press a button for a navigator. Of course, this is a new finding, and U of C and others will have to work out, okay, what are they going to do about all this bias in notes? And so those of you that are providers can probably talk about education initiatives or how you clean up the notes in EHRs.
This is something that comes up over and over again, right? I mean, when you elevate the patient voice, when you actually try to seek the patient voice, which everybody here in this panel is extremely close to, then this kind of problem where what's in the note, how it affects someone's diagnostic journey in a way that's far from optimum, becomes more important to address. And I think that's where we're hoping that the process from the project that we've done is a way for the research world to advance utilizing the findings from patients, that type of study that you're talking about, Anne Marie, that it would be very important for patients and patient advocates to know about and advocate for change. So I love the question here. What happens next? How is that information that we now understand more in detail, how these biases get baked in and how they affect diagnostic journeys in very adverse ways? What happens to change that? What are the changes that are needed? What would be the solutions? Helen, you were going to say something though.
Well, no, it's just the notes are now in the patient portal. So people need to use their patient portals. I think as long as patients are reading the notes, I think the people writing the notes would be more careful about their language.
Mhm.
I think one of the interesting things will be how that turns out. I mean, my husband was hospitalized recently, and my goodness, I'm an avid reader of notes, but even I gave up. This whole medical record there, I thought, this is a need to know basis. I'm not going to read this whole thing. I got about halfway through, but so it's there. It's there.
It is there, but I think, I hate to beat a dead horse, but if you don't realize that the language that you're using is, it's subjective and sort of leading toward biases, then it's not going to change because there's no recognition of doing something not quite right, right? And so I'm not certain. One thing I've learned over the years is that clinicians really respond to data, but data that they believe is valid and reliable and accurate. And so, they don't really like qualitative data. So how do we quantify this stuff so that they actually believe in what it is that we're seeing? That's really the question, I think.
Mhm.
I think it takes a survey, and I think it takes patient responses. Those two things. Survey of patients about their notes.
Yeah, I'm not sure if all these notes, though, are easily accessible to the patient. I don't think that when a doctor writes in the notes that they have access to, that quote, patient is aggressive, I don't think the patient sees that note.
It depends on how they're shared. One of the things that I know, Suze, you put up the other slide here about the principles we developed in the project, and the last one about having patient engagement. I feel like we're demonstrating this right now, right? That if there's a principle of going straight to the patient and their care partners and advocates, Helen, what you said about seeing your husband's notes, and start actually saying, where are the problems? What can we do about those problems? That then the solutions that are imagined, including, what you just said, Anne Marie, some of these notes might not be seen by everybody, but sometimes they are. What happens then if we go to actual co-design and co-work on this in a way that says more people join in, keep joining, we need more people joining, then we'll create surveys that are able to systematically get the information that we're hearing in these kinds of forums. Without starting with this kind of work, we wouldn't create the right surveys even. So that's just my tie into the process side.
Yeah, I know Monica Peak mentioned that if she felt that some of the things could be addressed by, like, instead of saying non-compliant, for instance, maybe you say medications unaffordable,
Yeah.
or medications had side effects,
Right.
medication, all the different reasons, rational reasons as to why a person might not take their meds,
Right.
instead of the word non-compliant.
Right. They may not be taking their medication because they're food insecure. They read on the medication bottle, take with food, and there is no food to take. So, these are some of those factors. These are some of the things that we're thinking about from within the community health center perspective, what they deal with day in, day out with their patient populations.
Right.
It's so critical. And it's to your point, Kathy, we transitioned into this slide because you all were discussing so many of these aspects. These are the sort of the foundational areas we have to keep focusing on when we're tackling these issues. There's one more question. Yeah, non-adherent is a better term than non-compliant. But even then, I think what we're really talking about is motivation. What's the motivation? What's the reason these things are happening? And avoid that blame language. I cannot believe we are already at time. I wish we had a whole nother hour. Maybe we can do this again sometime. It was wonderful to be with all of you. And certainly any participants who have additional questions, want to continue the conversation, SIDM does have a listserv. If you haven't become familiar with it, you can pose some questions there. But I want to thank all of our panelists. Thank you so much I'm going to go through my row the way you appear: Anne Marie, Christy, Helen, Jeanette, Kathy. And thank you, Marie, for running the show for us. Wonderful to be with all of you and a fantastic conversation. Thank you all so much.